Thank you for joining our webinar series on implementing evidence-based practices. So without further ado, I'd like to go ahead and introduce Dr. Vivian Brown.
Good morning, everyone. Okay, well, let us begin. Welcome to all of you. And so, as you can see from the agenda, we're going to spend some time with implementation of seeking safety. This webinar really is focused on the implementation. We're going to review sessions and adaptations and implementation drivers, then discuss measuring the fidelity, and I will share some outcomes of seeking safety from a national project. As you can see, I've had over 16 years of experience in implementing and supervising seeking safety. And I want to say that it has been one of the most exciting group interventions in my career. And, you can see it's a 40-year career. So I'm very pleased to be able to present to you regarding the implementation. So let's get started. As we talk about trauma, stages of trauma recovery defined by Judith Herman were 3 stages. Stage 1, establishing safety, is really the one that we're going to focus on today because it is trauma stage 1 that most of the group curricula focus on. And stage 1 really means, as you're seeing, what we're securing safety, stabilizing symptoms, and fostering self-care. But what stage 1 interventions are cognitive behavioral. They're teaching coping skills. They're usually group curricula, but they can be done individually, which is extremely important. And that stage 2 and stage 3 are done most often individually and after the person has really understood the connection between trauma and their addiction and their other mental health issues. 5 key principles are safety, that the treatment is integrated, substance abuse, mental health, and trauma. Focus on ideals, and we'll talk a little more about that as we get into the sessions. 4 content areas: cognitive, behavioral, interpersonal, and case management. Now, the treatment topics are very important, I think, in the way Dr. Lisa Najovitz designed this intervention. As I said, it's very exciting, and it's what I call flexible with stretchability, because while Dr. Najovitz has given incredible 25 topics, she designed it so that we're allowed to change the order of treatment topics to best meet the needs of the client population. My agency implemented a 31-session format, and I'm going to show you those 31 sessions and tell you how we got there. So you're looking at breaking up some of the sessions. The ones that say 2 sessions, we took the 25 topics and broke up some of the sessions. And I'm just going to go through that, but tell you how we got there. First, we started with a training by Dr. Lisa Najovitz. So all co-facilitators in our program were trained in seeking safety by Dr. Najovitz. When that ended, I and my project director for the big research project, the national project, Women with Co-occurring Disorders and Violence Study, we then spent 10 weeks going over every topic of seeking safety. When we finished that, the staff were asked to pilot them and pilot a number of sessions and then come back and really work with all of us together, deciding on the order of the topics and the splitting the sessions into 2. And so you can see that certain ones became very important to our staff. They said, we think this should be moved up quickly. We think this should be divided into 2 sessions. I think that is extremely important if those of you are still in early implementation. I recommend that you do something similar because it really helps you own the intervention. When we get to the next 12 sessions, this number of sessions, CTN is Clinical Trial Network. National Institute of Drug Abuse did additional studies, research on seeking safety. They decided to select 12 sessions in consultation with Dr. Najovitz, and these are those 12 sessions. And the 5 sessions are the sessions that Dr. Najovitz says, if you only have a short period of time, here are the 5 sessions she would recommend that you do. I want to say a little more about that because we also felt that this could be used as an orientation group. And we're going to talk about orientation groups later when we talk about working with men. So you could use this as an orientation group to help people understand what's going to happen in the group and get more comfortable with it. And we had the 31 sessions in residential treatment. If I were to start with outpatient, I would start with the 5 sessions. So a recommendation. So the session format, you have check-in, and you're asking each person in the group, how are you feeling, what safe coping have you done, etc. Then the session goes after you finish the check-in, and you want maybe 5 minutes per person. And one of the best things about check-in is that you really can follow up with any serious issue that someone names, such as, yes, I used drugs this past week, or they had an angry outburst at their child, or they had suicidal thoughts. This will probably come up in the check-in, and then after you get into the topic, you may want to pick up that whole issue with the client. Then once you're into the quotation, every session has a quotation, and the clients are asked to really reflect on what that might mean. You then have the topic which you relate to. It says women's lives here. Of course, it could be men, it could be adolescents. And then there is a closing section. So I want to talk a little bit about beginning implementation issues. I noticed that some people were just still in contemplation stage around implementing seeking safety. If you have not begun to deliver the intervention, my recommendation is to read the first 2 chapters of the manual, which is the overview in conducting the treatment, then select the topic that appeals to you and try it with a client. You can do that individually, and you then become more comfortable with it. Also, my recommendation is to sit in with an experienced facilitator who is running a seeking safety group for a few sessions or the whole set, so that you again become more and more comfortable with it. And I like to say that this is one of those opportunities, seeking safety, where you can go into the group clutching the curriculum. No one is going to feel badly because you're having all the handouts. The clients will have handouts, and you can still have your curriculum in your hand. So the issues about groups, if at all possible, I recommend having co-facilitators. We did. We had a clinician, a person trained clinically, social worker, psychologist, psychiatrist, psychiatric nurse, and we had a recovering person, consumer client who helped co-facilitate. I recommend the co-facilitation because, one, you have the 2 people with their perspectives. You also have someone in the group if someone does have some serious issues, such as an emergency or suicidal thoughts, and you want to take them outside the group and have time with them, someone else can stay in the group and continue the group session. Some people worry about where am I going to get a co-facilitator. As someone who was a graduate student at one point, I would say if you have access to graduate students, they make wonderful and enthusiastic co-facilitators. If you don't, you also have peers who will have graduated and been trained as a possible co-facilitator. The size of the group can vary, and I put 6 to 16 plus. We've had groups up to 16, but I want to share also with you that I have had a wonderful experience with a program called Choices in a jail setting where they did not want to break up the pod, the women's pod, and so they implemented Seeking Safety in a classroom setting with about 35 women, and it worked beautifully. So again, Dr. Najovitz allows for the flexibility, and you can have very large groups. If it is large, you may want to cut down the check-in and check-out, make it 2 questions instead of the 5 questions for check-in. Also, what's the best time to implement has been a question that a lot of people raise. We had the Seeking Safety group start within 1 month of the person's entry into residential. For outpatient, again, I would do the 5 sessions as an orientation, and you're in. That could start immediately. So the best time to implement is very quickly, and I know sometimes that makes people nervous who are running the groups, but you can take it from our experience that the groups ran very well. These were the most loved groups I have ever run in my career. Women and men kept coming up to us and telling us how wonderful the group was, and they wish they had had it in previous treatments. So it can be done successfully in mixed gender groups. However, I always recommend single gender groups to really begin the Seeking Safety, because I think at that point people who have been traumatized may have problems with the mixed gender. We know women don't always speak up when men are in the groups, and men may not want to be talking about their vulnerabilities in front of the women. The other key message is to keep groups safe, and that means by not opening up graphic details of the trauma. And so we'll talk more about that probably later, but just if someone begins to be triggered in the group, what we do is we stop the action, we use grounding techniques, which is one of the sessions, and we calm everything down and continue. And as I mentioned before, if someone still remains agitated and you want to have one of the co-facilitators take them out of the group, you can continue the group. But we don't want everyone in the group triggered, and so that's how you stop the action. So some key points about implementation. Find your own style. Well, this again, one of the great things is that the flexibility of the model really honors the facilitator's own style. So some of us, move quickly, some slower, some like working with worksheets, some don't. Whatever is your style, you can work it into Seeking Safety and not have to worry about it. Many people bring in humor and artistic exercises. We'll talk a little bit about that when we get into some of the adaptations for adolescents as well. Identifying the trauma themes. Here is, if you're dealing with mostly substance abuse clients, they will focus on their addiction, particularly if they've been in previous treatment. They've been told, focus on your addiction, you're an addict, focus on it. But we need here to explicitly raise the trauma themes so that the clients become more aware of them. So for an example, I know Dr. Najovitz gives this in the manual. The hopelessness you're describing is very common in trauma survivors. And then so you're linking the hopelessness with the trauma and bringing that into the person's cognition, that they really understand substance abuse and trauma go together. Similarly with mental health issues of depression and anxiety, very same thing. Rehearse the tough cases. For each topic, Dr. Najovitz has given a list of tough cases, challenging statements clients may say in relation to that particular topic. So, for example, client says, I don't want to stay safe, I want to die, which is, of course, a tough case, and you may hear that in the group. One of the responses could be, I really hear your feelings of wanting to die. I also wonder whether there's another part of you that wants to survive. So that, again, you're helping them move from the stuck place. Learning ways to redirect and contain. Again, sometimes we need to interrupt or stop the client. Particularly, one of the times you may be doing this is in check-in, where you might have to say, let me ask you to stop there. I want to make sure everyone gets a chance to check in. And again, done very softly and comforting, that the person knows they're going to have a chance to talk in the group. The power dynamics, of course, many clients who've been traumatized have experienced an abuse of power and have strong reactions to power and control. So they may be overly passive, or they may be overly dominant. They may project power issues onto the group or onto you. And they're probably watching you and how you're going to use power. And this is where it's extremely important that we say we are striving for an empowerment approach, where we invite choices, we ask permission to discuss certain things. But choice is a very important issue for the trauma survivor. Using alternate methods for clients with reading problems. This is something that we found in the research study, the national study, and alerted Dr. Najovitz to this, and in the article that's in the references that I'm first author, Dr. Najovitz second. We really were concerned because the handouts are wonderful, but many of our clients at Prototypes were unable to read. And so what we did is a number of things. We had clients who were able to read small sections to help others. We used mentor moms and big sisters to sit with the clients and read it to them. And we summarized in the group all the points. So it was always read, certain points were always read aloud, so that no one also had to feel uncomfortable admitting that they could not read in the group. And then discuss and rehearse skills. Most clients don't typically move into rehearsal of skills by themselves, so we're going to talk a little bit in the next slide about role-playing, and that's how we help them rehearse the skills. So rehearsing the skills, you can do a walkthrough, which is you say to the person, if you felt like using, whom would you call? And that's during the asking for help session. Because we're talking about asking for help, here's a way to rehearse the skill. Who would you call? What would you say? And you have the person role play that with you. And in that way, the client really tries out new ways of relating to another person by practicing, particularly if it has to do with unsafe behaviors. Identify role models. Clients, you really ask them to think of someone who already knows the skill and explore with them what the person does. And so that person becomes sort of the role model for, let's say, asking for help. Say aloud is where we have the clients practice a new style of self-talk out loud so that they can practice what they've been saying to themselves in their heads, we have them say aloud in the group. And then people can really process that. Again, process perceived obstacles. What might your partner say if you requested safe sex? And that this helps the person really move through the obstacles that they're perceiving, because other people in the group can also help them with that. You hear I'm saying something about safe sex. One of the things, again, that's so wonderful about seeking safety is it's not only seeking safety around the trauma and around substance abuse, and about suicide, but also HIV/AIDS, another safety issue for our clients. Involve safe friends. That we really encourage the clients to enlist help from safe people like their sponsor, other friends who perhaps may not use drugs or may not be doing something that's more destructive. Replay the scene. Clients identify something that went wrong and then go through it again differently so that they can replay it in a more positive way. And making a tape, which I think is an excellent suggestion that Dr. Nadjevitz raises, which is that you can create an audio tape for clients to use outside of sessions. One of them, the tapes may be grounding, so that they have that with you, with your voice, so that they can take you and the grounding skill, coping skill with them. Cultural issues, very important. We discuss in the sessions cultural messages, historical trauma, racism. Many of the groups that will be in, many of the individuals coming from groups who have experienced historical trauma and racism. And it's really important that we recognize that and allow the clients to really speak to that issue. We also provide cultural examples. So as you're going through each session, you want to include cultural examples, particularly for the groups, the racial ethnic groups that are sitting within your groups and in your program. We discuss spirituality and religious coping as part of the Seeking Safety. And Seeking Safety has been translated into Spanish and many other languages. In fact, usually just keeping up with the languages that Dr. Nadjevitz has been able to translate and back translate Seeking Safety into keeps growing. You'll see the website for Seeking Safety at the toward the end of the PowerPoint. And so if you're concerned about which language you may be able to use, I recommend that you go up on the Seeking Safety website, and you will see all the languages that have been will be available to you. So let me talk a little bit about other adaptations, because people wonder. The big national study that we did was focused on women, but Seeking Safety has been used with men, adolescents, military, and veterans. So let's look a little bit about some of those issues. With men, bonding is extremely important, like warriors or sports teams. So bonding with other men is a theme. Anger problems, another clinical theme, and we recommend healing from anger, which is one of the sessions, be one of the sessions that you focus on fairly early. We had an interesting experience. I served on the SAMHSA National Advisory Council. We had the opportunity to go to a trauma-informed prison system. And when we talked to the women, everyone talked about how wonderful it was that they had trauma groups. When we met with the men in prison, we said something about, how do you like your trauma groups? And they all said, we don't have trauma groups. And so we were a little puzzled by that. Well, it turned out that what they did is they called the trauma group Healing from Anger or Anger Management. So this is something that you can do if you're doing Seeking Safety with men. calling the treatment training rather than treatment, because again, this is a more palatable word for the men. Issues with authority and control is a clinical theme with men, so important for that to be discussed in the sessions. And trauma and substance abuse violate the traditional male role of being strong and in control, although many people like to believe they are in control of their substance use. Hopefully by the time you're working with them, they have understood that they're not in control of their substance use nor the trauma. But it is a difficult issue when working with men. And intimacy and feelings is another area where men are not as comfortable dealing with intimacy and expressing feelings in a group. We talk about changing language, suggested instead of seeking safety. You can call it seeking strength for men. This is some work not only with seeking safety, but also with men in the military. Asking for help, you may want to translate to collaboration and working together. Compassionate self-talk, you may want to talk about being a good sports coach. Healing can become dropping baggage. These are more comfortable to the men and have been used in a number of different interventions. Use an orientation group for men. Again, the 5 sessions would be great. If you want to do less than 5, that's also good for an orientation, to present a few of the topics in psychoeducational format. You can add additional materials around anger management. Some of the anger management tools you can use as handouts. Rehearse the skills, and again, if needed, shorten the check-in and use 2 questions about good coping and any substance use or unsafe behavior. The men particularly, these are the sessions the men particularly liked and were well received, and that's healing from anger, as we just talked about, PTSD, taking back your power, coping with the triggers, integrating the split self, and I don't need to read them all to you. Grounding, by the way, is something that everyone, men, women, the military, adolescents, all rate positively. In our research, women rated most positively self-nurturing, honesty, when substance control you, setting boundaries, safety, healing relationships, and the grounding, which is detaching from emotional pain. For adolescents, a number of the adaptations have been to shift the quotations rather than use the quotations in the manual, to use others, and particularly music lyrics, because it really appeals to the adolescents, to use relevant examples, school, parents, dating, sports, music. Include fun and engaging exercises. Again, artwork and music seem to be the most well received. And to have sessions with the parents using the topic, getting others to support your recovery, which really does add more support for the adolescent. Oh, sorry, I think I skipped over. Oh, for military and veterans, again, consider the name Seeking Strength. Name the group training rather than treatment, and address the concerns for the military, which are issues with their own perpetration of violence, which we know not only have the military people, and I'm going to say men in this case because more men, but women as well, have seen people blown up, which is traumatic. But the other side of that is that they have perpetrated violence, and that has to be addressed, because that's the one that often doesn't get addressed in the trauma interventions. Betrayal, difficulty readjusting to civilian life, and traumatic brain injury. Just to point out that, of course, we now have military people, men and women, coming back from combat who have both trauma and traumatic brain injury. We have never seen this before, this extent, because we couldn't save people's lives with the kind of traumatic brain injury we're seeing. So this is a very important issue in the trauma interventions. And for women, you may want to address the high rates of military sexual trauma. Again, that's an issue of betrayal because they're being sexually abused by people who are their comrades. So, implementation drivers. Let's talk a little bit about some of the important issues that you may be struggling with, which is staff selection. So I want to go back to what I talked about earlier, which is we trained all of our group facilitators. We trained them and then they piloted. What we found, and by giving people choices, when they piloted, when they went through the 10 weeks with myself and the project director, many of the staff came to us and said, I have not dealt with my own trauma issues. And they wanted to opt out because they had unresolved trauma issues themselves. And we, of course, allowed them and arranged for them, if they wished, if they wanted to deal with those traumatic issues, we arranged for them to have treatment outside of the program. So that's one, I think, major issue about staff selection, is that you may all have group facilitators. This is an excellent group. If you love doing group, you're going to love doing Seeking Safety. But because it does have the focus of trauma throughout all of the intervention, you do want people to feel comfortable, and if they have unresolved trauma issues, you want them to be able to opt out. For training, you heard of our experience. We had Dr. Najovitz train everyone first, and then we continued the training so that people had the experience of going week by week over the content areas. For those of you who have not been trained, you do need a Seeking Safety training. This is not a Seeking Safety training. This is an implementation training. So if you need training, Seeking Safety training, you go up on the Seeking Safety website and you will see a section that says if you need training. Dr. Najovitz will arrange for the training. For coaching and supervision, it's important for all of us to have supervision, particularly trauma-informed supervision. So we also recommend all supervisors sit in the training for Seeking Safety and then have additional training around Fidelity Monitoring, and we're going to talk about that in a little while. But that would be a separate kind of training. And you want to make sure that the supervision is always available for everyone, and that the goodness of fit with the target population. As you can see, the target population can be men, women, adolescents, military, veterans, not children. This is not an intervention for children who have been traumatized. I want to say that in our research study, the national study, we really looked at 26 facilitators and their use of the model. 60% reported it took them less than a month to feel comfortable with the model. So just know that, you know, if you have the opportunity to have the training, to go over the content, to have people pilot and then run them, you're going to see the comfort level go up pretty fast. The interesting thing is the majority of clients in that same study reported they felt comfortable with the group in 2 weeks. So the clients feel extraordinarily comfortable with the intervention. So I'm going to stop for some questions.
Hi, thank you. Dr. Brown, can you hear me?
Yes.
Okay, great. We do have a couple of questions that have come from registration and some of the participants. The first is that they heard you briefly mention that seeking safety can also be implemented one-on-one versus in group. Can you talk a little bit more about that, please?
Yes, excellent question. What's wonderful is that, again, Dr. Najovitz designed it so that you can take each session and do it individually with a client. And the reason we were excited about that is if you're running a group and a number of the clients don't make that group, they have medical appointments or they can't make it, their child is sick, you can then sit with them individually and go through the session, and they will then be able to catch up and be in the group the next week, and they're caught up with the group. If you like doing it individually, you can certainly do the whole 25 topics individually. So you do have that flexibility, and it's a wonderful thing. I just love the fact that you can have people catch up if they've missed a session.
Okay, great, thank you. Another question. How have you been able to keep clients engaged in the Seeking Safety program?
Another great question. I have to tell you, in my whole career, I have never seen so many people love an intervention, particularly a group intervention, like Seeking Safety. So in the residential, we had no problem having the people engaged. In outpatient, slightly different, because in outpatient, of course, people are ambivalent. You don't have them captured for a period of time in residential. We have a long-term residential program. So, so I guess what I'm saying is for outpatient, I'm going to focus on that because of the engagement. I do think doing the orientation sessions will help engage them, because when you first say to a person, we want you to join this group, they immediately don't want to do it. In California, we had our Proposition 36 program in the counties throughout California, and people tried to do Seeking Safety in the outpatients, and of course people were saying, I don't want group, I want only individual, I'm not going to come. So the way to really engage, I think, is to do the 5 sessions, if you can keep them even in 5, but at least try 2 to 5 sessions where they understand what's going to be happening in the group, and to set up an orientation group and run it, have the people feel comfortable. You've got the 5 sessions. You can choose, safety, you can choose grounding, and have them understand how it's going to be run and feel more comfortable with it. We also, I've recommended that parents, to have parents, particularly if you're having the family drug courts or family interventions, that you have parents come in. The child could be in a cognitive behavioral, particularly trauma-focused intervention for the children, but the parents come in and have both parents, if they're available and willing, to come in and, again, do an orientation of the 5 sessions of Seeking Safety. And they do become very engaged.
Right. Thank you. And I just wanted to make one comment. Some of you may notice as we go through the slides, some of the slides are hidden for the purposes of today's presentation, but they are available in the handout that you received.
Thank you, Mariana.
No problem. Thank you. Please remember to use your questions box should you have any questions. We're going to be taking questions throughout the presentation and also hope to allow some time at the end for any additional questions. Thank you.
Okay, well, thank you for those great questions, and I'm going to continue now with, now we're talking about measuring the fidelity of Seeking Safety. Those of you who are not familiar with fidelity monitoring, when you have an intervention that's evidence-based, and that means that it's been researched and proven to be very effective, you usually don't want to modify it, which is a little strange when I've just said one of the most exciting things about Seeking Safety is that you can adapt it and add things and change order, etc. So one of the ways that we ensure that you're conducting the model the way it's supposed to be conducted is by fidelity monitoring. Dr. Najewicz has developed a Seeking Safety Adherence Scale. It is available through the website, and I want to make another point here, which is that those of you who would like additional training, support, Dr. Najewicz has a 4-session DVDs, 4 DVDs, one of which is on doing the monitoring, the fidelity monitoring, using her adherence scale. I'm going to speak to the adherence scale today, but I recommend that you order the set for your program, and the supervisors can sit with that DVD, and she goes through the adherence scale. And it really helps. There's also a very abbreviated worksheet that supervisors can use, sit in the session, use the worksheet or the adherence scale, and it's really to help the facilitators enhance their skills. It's not as a punitive measure. It's to really help people understand that there are certain parts of the intervention that you do not want to change, and there are some that you can change easily. Again, you can do it either individually or group treatment. The fidelity monitoring, and the monitoring covers the areas of the format, the content, and the process. So I'm going to tell you a little bit about what that might look like. So the components, did the person spend enough time on the components? Did they do the check-in? Okay, did they do the check-in? Did they check in all the clients? Was it complete? Was it not complete? And there's a scoring sheet it wasn't done at all, and to very helpful. That's one area where you don't change doing a check-in, but as you heard me say, you can cut it down to 2 questions if you have a very large group. Another one is case management. There is a whole case management session, and again, for the fidelity, was it done? Was it done in a way that addressed all the referrals and needs, all the way to, everything was covered. So let's say you're a supervisor, you're sitting in, and the facilitators covered about half of it. One of the things would be that you would say to them, you didn't cover the whole session. Perhaps this is one of those sessions that you want to split into 2, because you had a great session, but you didn't cover all the material. Let's do a second session. Again, here are the ways to enhance and monitor the implementation. Another area would be substance abuse. Was there any mention of substance abuse, all the way to the considerable amount of time spent on the substance abuse and the risks for use? So and the same thing with PTSD. I want to mention something about the PTSD. We implemented it by saying PTSD trauma. And we explained to the clients that we would be talking about post-traumatic stress disorder / trauma, and eventually we just started to say trauma, because the post-traumatic stress disorder is a little long, complicated, and we felt didn't add, once the person understood what post-traumatic stress disorder was, and we kept linking that with trauma, which is the broader category, then we could drop the post-traumatic stress disorder words and just quickly say the trauma. I'm not going to go through all of the sessions on the adherence scale, but I want to get to some of the other issues about process. Let me just, I have the monitoring thing right in my hands here. So let's say ability to listen. there is a section. Did the facilitator or facilitators hear the clients or patients accurately? Did they impose their own understanding incorrectly, etc., all the way to did an excellent job. They heard the patients with understanding and sensitivity and accuracy, both verbal and nonverbal. And again, another section is the effort level. Is the facilitator too passive? Can they pick up a little more work, an effort in the session? So all of these things are on the adherence scale. And my recommendation is for the supervisors. Definitely get the DVD, call the supervisors together, have time to go over the DVD together, and then have a real discussion and a group, a supervisor's group around monitoring. And for those of you who are being monitored, I hope you understand the monitoring is really to make sure that you're conducting it closest to the way the model should be done and to help you enhance your skills. So let me stop there. There may be some questions about Fidelity. No questions, and I will continue. Okay. What I want to share here is a little bit about the national study that I keep referring to, and you're probably wondering why do I keep referring to it and I'm not talking about it. So very quickly I want to tell you about Women with Co-occurring Disorders and Violence study, affectionately known as WCDVS. This study was a 5-year national study funded by SAMHSA, and it was implemented 1998 to 2003. It set the stage for a nationwide dissemination of trauma-specific and trauma-informed interventions. 9 sites in the country were tasked, we received funding, to implement best practices for women who had substance abuse problems, mental illness problems, and histories of violence and trauma. 4 of the 9 sites implemented Seeking Safety. That was the largest number of sites implementing one intervention. And my agency was one of those sites. There were almost 3,000 women enrolled in the study, so it was a very large national study. In order to be in the study, they've had to be 18 years or older with histories of mental health and substance abuse services use. They had to have a minimum of 2 previous treatments, so either 2 substance abuse, 2 mental health, or 1 of each. And they had to have, of course, histories of physical or sexual abuse. And you can see the ethnic racial breakdown. There were some sites that were predominantly Caucasian. Now, I'm showing you some of the local outcome study from Los Angeles. These I know backwards and forwards. That was prototypes. We did a baseline, and we did 3-month and 12-month assessments. And so for those of you who may be interested in doing some research, the measures we used were the ASI, the Addiction Severity Index, the Brief Symptom Inventory, which is the BSI, Post-Traumatic Symptom Scale, PSS, the Life Stressor Checklist, which is a revised checklist, and a Coping Skills Scale. Now, I do have to say something about the Coping Skills Scale. We were the only ones that used the Coping Skills Scale. It was a scale that Dr. Najewicz developed, and we added to it with her consultation. And you'll see some of the results on that and why we were very excited about using it. Because Seeking Safety has such a wonderful focus on coping skills and teaching the participants coping skills, we felt it was extremely important to really see, did they learn and use the coping skills? Also want to mention on the Seeking Safety website, you will see many other measures that Dr. Najovitz recommends if you want to do research. So you can see that here. So let me show you some of the summary of data. The women in the, we had intervention groups and we had comparison groups. So the comparison groups were in agency outside of our catchment area. So we could really ensure that we were not getting any confounding. Women in the intervention group were less likely to drop out than women in the comparison group. Use of coping skills increased from baseline to 12 months for the intervention group, and what was interesting is slightly decreased for the comparison group, which we have no idea why it would have decreased and not stayed the same for the comparison group, but it did. But there was a definite increase in use of coping skills. There was greater improvement on post-traumatic symptom scale, and not only did the women in the intervention group gain more in coping skills than the women in the comparison, but these gains were specific to the women who completed the treatment. And I should also say that what was really interesting was at 6 months, and it depends, you know, how long you follow people. 6 months after the intervention, we saw a significant drop in substance use. That was the most significant first finding, 6 months, which compares to a number of research studies that say we really should have a 6-month substance abuse treatment program, even though, you know, 90 days has shown some progress as well. But 6 months very clearly here, we had substance abuse decrease significantly between the intervention and comparison. The trauma, the PSS, post-traumatic stress symptoms, started to show tendency to decrease, but at 12 months, significant difference, and 12 months significant difference in other of the mental health symptoms. So again, I'm going to stop here for questions.
Dr. Brown, can you hear me?
Yes.
Okay, great. We do have a couple of fidelity monitoring questions that came in, so if it's okay, we'll start with those.
Absolutely.
Okay, great. One of the questions was, do you have any suggestions for how to do fidelity monitoring in individual sessions?
Same as for the group. If the client is comfortable with a supervisor sitting in the session, then the supervisor could sit in there and be monitoring. If the client is not, and of course it's always the client choice in this situation, then what the person doing the individual intervention could tape the session, and again asking the client if that's comfortable, because they want to hear it, and their supervisor may want to consult with someone to hear it. And then again, the fidelity monitoring can occur with the tape. For research purposes, the adherence scale, the full complete adherence scale, is used so that is always checked very carefully. But in individual, you do have to have the client feel comfortable with either being taped or having somebody else, or behind a one-way mirror.
Thank you. Another question, and I'm sure that one you've experienced in running your organization, is how have you been able to address the impact of staff turnover on the implementation of an evidence-based practice like seeking safety?
Another fabulous question. Turnover is one of the really significant problems, I think, in implementing any evidence-based practice, because we spend so much time training and making sure that the staff learns the intervention. And then if there's turnover, you sort of lose that knowledge. What we did, of course, is to train as many people as possible, and not everyone, as you heard, some people opted out of doing it at that point, but came back and later wanted to implement, but to have enough staff trained so that if there's significant turnover, if you only had 1 or 2 people seeking safety, you would have a problem. I can tell you that. So the more, the better. The more people trained, the better. And then for prototypes, I continue to go in and train. They ask me to come in every year and do an additional training for the new staff that have arrived, because they're always developing new programs. So I go back and do the training.
Thank you. And then one more question about fidelity monitoring. How often should you do it?
Oh, also a great question. In the beginning of the implementation, again, if you're doing it and a number of, let's say, 5 facilitators are trained, you want to give a good number of months. As we said, after a month or 2, people are comfortable. You want to make sure to monitor throughout those couple of months. Then to have the supervisor drop in periodically to make sure, because we all tend to sort of get a little lax in the intervention and following carefully as we get more and more comfortable with it. So you may want the supervisor to go in and just to make sure, again, its flexibility is wonderful, but you don't want to make it so flexible that you've lost some of the really important components. In individual, of course, you're going, if the client is comfortable, I would say to tape for quite a while.
Great. Now we have one question that you addressed a bit at the beginning, if you don't mind going back. It's more about implementation.
Absolutely.
Some folks have said staff is concerned that some people in the group may not be ready to talk about trauma or not really ready to deal with it. You talked a little bit about how staff could address it in the group. Can you talk a little bit about how you've addressed it with your staff, if you've ever seen that kind of reaction from staff members?
Well, if staff are concerned about addressing trauma, that hopefully you're going to spend considerable time before implementing seeking safety with the staff. So we usually recommend, and this, I'm glad you're raising this question, because we usually recommend everyone in the staff gets a basic trauma training. That's not seeking safety. That's a basic trauma training. And when we say everyone, we mean everyone, including receptionists, maintenance people, anyone who comes in contact with the clients. And the reason for this is we want everyone to feel a little more comfortable. And I'm going to use the receptionist as an example. Often we'll hear the receptionist say, when they hear someone on the phone crying and screaming, and they're talking about some abuse, some of the receptionists said they wanted to hang up because they didn't know what to do. They didn't understand what was happening, and they hadn't been trained. So again, a basic trauma training for everyone in the entire program. Or network, if your program is a network, like the Family Drug Court network or some other kind of network. Everyone gets a basic trauma training. Then there are the trainings, let's say for the group facilitators, the seeking safety training. For the supervisors sit in the seeking safety training, and then they have their own time to go over training of the Fidelity Monitoring. So, and we also ask administrators, the managers, to take a little time to sit in the basic trauma training too, so that they get the same knowledge that everybody else has. So someone doesn't walk up to the executive director and say something, and the executive director doesn't know what they're talking about. So it's really multi-leveled training. For seeking safety, it is only for the people who are going to facilitate that. But if we've had many staff who say, I don't want to facilitate, but I want to sit in the training. Said, great, please do. And I'm sure some of the people who sat in on the training may have been survivors.
Thank you. A couple more questions. The first one is, could you define who the comparison group was in the Women with Violence and Co-occurring Disorders study? A little bit more detail about the differences.
Absolutely. For us, for prototypes, we used some of the best women and children's programs in Los Angeles. We wanted to have a rigorous comparison site. So I want to emphasize that because there was one site that used methadone maintenance as comparison sites, and that is a little less a comparison site than using another women and children's residential treatment program. So we picked some of the best, but we picked some of the best that were outside of our service planning areas. So, and if those of you who know how large Los Angeles is, we're larger than some states, we picked sites that were across the entire county, which is like 50, 60 miles away. So again, because you don't want someone to hear, oh yeah, prototypes is using seeking safety, and you should be using that. So, and we blinded the study, which means everyone who was doing the research teams were blinded. The research people who came in and interviewed the clients were all blinded to who was the intervention group and who was the comparison site, which makes for a more rigorous evaluation.
Yes. Thank you. Another question, and this is specifically about clients that might be child welfare referred.
Yes.
Are there specific areas you report back to social workers about, or do you find that there are certain components of seeking safety that child welfare wants to know about?
We never had, we work very closely with child welfare at prototypes, and we never had a request specifically around the seeking safety. We, of course, we have very strong relationship with child welfare, so we even went out with the emergency response workers to do assessments and evaluation, and then take the family in. So we have confidential agreements, what can be shared and what not, and of course if there's any danger to the child, we will immediately alert child welfare for that. But because we have the children there, we have much better access, particularly in our residential, we have much better access to helping and enhancing the skills. And we really see the difference when you have this very strong tie with child welfare and the substance abuse treatment program.
Great. And then we have one other question, which we may be able to follow up with also with the National Center for Substance Abuse and Child Welfare, which is there's a lot of talk about trauma training going around. And when you spoke about staff participating in a basic trauma training, what are some key components that you would identify are part of what a basic trauma training would include?
Great question. We want people to understand, one, the prevalence, what is the prevalence, the incidence of trauma in our populations. For so many years, people, both substance abuse side and mental health side, did not understand that the majority of their clients had all been traumatized. And over the last couple of decades, we've been doing research that highlights that, so that the figures have been up to 99% of women, a little less for men, but 99% of women in substance abuse programs have been traumatized. And in mental health, it's about the 95% range. And as I said, men a little less, but now if it's military, then the men, very high rates. As methamphetamine spread across the country, very high rates. of incidents of trauma. So it's what we're trying to get across in the basic training is that trauma is the expectation, not an exception. And that we really have to focus on trauma. People have to understand the impact of trauma on the client. So you've got how frequently people experience it, what's the impact on them, and the impact is usually that the trauma occurred before the substance abuse, right? So substance abuse becomes an impact. Depression, anxiety, impact. Physical health problems, impact. The list becomes longer and longer in terms of impact of trauma. And what's been very important around the child welfare issues has been that we finally really are able to communicate that, yes, the child who has been traumatized is extremely important and we must keep them safe, but the parents most likely have been traumatized themselves. And unless you understand that and respect and understand the parents and their trauma, it's going to be very difficult to keep the family together. So it's very exciting now that substance abuse, mental health, and child welfare are all working together, because this is really taking the field to a different level. I want to also explain the difference between trauma-specific and trauma-informed practice, because that has to be part of that basic training. And the Women with Co-occurring Disorders and Violence study brought that again to national attention. Trauma-specific interventions are those interventions, like seeking safety, that are designed to directly impact the trauma. Okay? But we also know that all practice needs to be trauma-informed, and the system needs to be trauma-informed. So child welfare, substance abuse, mental health, are all being trained now in becoming more trauma-informed, meaning that the system and the people within it understand what we are just talking about. Prevalence and incidence of trauma, the impacts of trauma, what it might look like, so that people understand that when someone gets in your face and starts yelling at you and says they're going to kill you, I always say, I know how difficult it is for you, but think trauma first. Because the trauma survivor is trying to get you to back off because they're afraid you're going to hurt them. So they're going to threaten you. So even the hostility that we experience is often most likely linked to trauma. And so it's important for us to understand that and to change our systems to become more trauma-informed.
Great. Thank you very much, Dr. Brown. I'm going to ask, Ken, are you on now?
Yeah.
Okay, great. I'm going to pass it over to you now. Thank you so much, Dr. Brown.
Thanks a lot.
Thank you, Mariana.
Well, thanks, Dr. Brown, for an excellent presentation. You know, when you speak of the high prevalence of trauma, of parents with substance use, mental disorders, and even parents in the child welfare system as well, and that we as systems that engage families need to expect trauma rather than be an exception. I think it also speaks to an expectation that the services that you just described, both trauma-informed and trauma-focused services, need to be an expectation for the services that we provide to families, and not an ancillary service or not a specialty service, but integrated into the fabric or the core of the services that we provide families and how we engage families. And you did that by addressing what has become really important components of implementing evidence-based practices and trauma services, by touching on the implementation issues, by touching on the measurement of fidelity and how important that is. There are many sites on this call today, on this webinar, for implementing evidence-based trauma services, including seeking safety. So that's such an important aspect. They're participating in a cross-site evaluation, And then measuring the impact and outcomes and the effectiveness of the intervention. Constantly getting feedback from both the consumers, if you will, participants, clients who are receiving those services, as well as the staff who are delivering those services. So we really appreciate the comprehensiveness and the way that you've addressed these critical components for really what needs to be a core fabric of what we provide and how we engage families. So thanks much for that. Well, welcome everybody, and I just want to thank you all for participating. Some of the recognition that I was going to give earlier when I was not able to connect with you, I would like to do that now. My name's Ken DeSergio, and I'm Program Director with Children and Family Futures in the National Center on Substance Abuse and Child Welfare. The National Center is supported by the Children's Bureau and the Administration for Children, Youth, and Families, and the Substance Abuse and Mental Health Services Administration. We are also the technical assistance provider for regional partnership grantees who are funded through the Children's Bureau. And our federal project officer, Elaine Stett, is on the webinar today. I want to express our appreciation to Elaine and the Children's Bureau for supporting our work today in this webinar, as well as SAMHSA, and ask Elaine if she'd like to say a few things before we close today.
Hi, Ken. Can you hear me?
Yes, we can. Hi, Elaine.
Hi, everyone. Dr. Brown, I just really want to express my gratitude for the presentation as well. I feel as if I could listen to you for hours, and so it was really wonderful. And then for the questions from those in attendance, they were great questions and really a lot to think about in terms of our work. And so I'll just add that ACYF is committed to facilitating healing and recovery and promoting well-being for children and families. And so this presentation is very timely and I think has added a lot of value to the ongoing work of the regional partnership grants as well as the other grants that the National Center serves. So in terms of helping us understand the experience of the children, families, women, men that we work with, and also to think about it in terms of fidelity evaluation, which is so critical to our work. And so again, thank you so much for the presentation, and my gratitude to the CCFF staff and the staff of the National Center for pulling this together, because I think it was very informative. Thanks, Ken.
Thank you, Elaine. Appreciate that.
Thank you.
There have been a couple inquiries about these slides. These slides, for those of you that are regional partnership grantees, we will post this on Collaborative Project Management, CPM. And for others, we will post these on the National Center website. If we could proceed, we have a couple of links for you that might be helpful. Dr. Brown has mentioned throughout her presentation Seeking Safety website and the work of Dr. Najovitz. So we've given you this little background information in your slides so you can see how to access that website as well. Okay. We can move, thank you, to the next slide. For those of you that are regional partnership grantees, I know there's a significant number of you on the call. We also have on CPM our forum, and that Dr. Brown will be available to us to answer any additional questions that you may not have asked today that may come up in the coming weeks. We encourage you to post those on the forum for the benefit of everyone, of all the regional partnership grantees, and we will be checking that forum and passing those questions along to Dr. Brown. This is how you can get in contact with us if you have specific questions. The voice behind today's questions was Mariana Corona, a research associate with Center for Children and Family Futures. And you see our website, our National Center website as well. And after this webinar, you will be getting a request to complete an evaluation. Please take a moment to complete our evaluation. Technology is a wonderful thing. You'll be redirected to evaluation upon exiting the webinar. I know that you'd be anxious to not do that or to leave the webinar. I'm looking at my clock. We have 9 minutes left, so we have not gone over our 90-minute allotment and your 90-minute commitment, so we should appreciate it if you would take perhaps 2 or 3 of those remaining 9 minutes to complete an evaluation and give us feedback, not only about today's presentation, but how we can follow this up and how we can continue to provide webinars around evidence-based practices and the other types of support and technical assistance we can provide through the National Center on Substance Abuse and Child Welfare. I want to thank Han and the team at our Children and Family Futures home office for straightening out our technical difficulties and getting us back on track. I want to thank all of you, each and every one of you, for spending some time with us today, and wish you all a happy, peaceful, and healthy New Year. And once again, Dr. Brown, thanks so much for your work today. We appreciate your presentation and your engagement with us in the coming weeks. Have a great day, everyone. Thanks again.